streaming live from Duke Spine Institute at the Surgery Center of Vieira here in Melbourne, Florida on the Space Coast. Our next patient has a herniated disc in his lower back at L5-S1 on the left side, and it is causing back pain and also a pinched nerve going down his left leg. So he's got, really doesn't have much sciatica, but he's got weakness now. And he and I were just talking earlier about the issue. Hi, Dr. Duke Majan here. And basically, his foot's getting weaker. So he's starting to drag his left foot. That's called the drop foot. We're going to try to fix this transforaminal endoscopic. All right, sir, are you ready? All right, good. So first thing I'm going to do, you're going to feel my hand touching you, okay? I'm trying to find the right place to start. So I'm just going to push around and find some bones here with my fingers, okay? Then I'm going to give you a little bit of numbing medicine. You're going to feel some numbing medicine, okay? The numbing medicine is going to like sting a little bit when it goes in, okay? So don't be upset when it goes in. If you ever feel discomfort, just say ouch, okay? Go ahead and say ouch when you feel discomfort. The important thing is I don't want you moving around, okay? I know, I apologize. Now are you an engineer? Aeronautics engineer. So you crawl around a lot like we talked about working on airplanes, right? We injected 6 cc's. Luis, where's the other one?
I know. I'd like to try first, but all right.
Well, I'll try it.
All right.
Yeah, we're going to need the other one. All right. So, sir, let me know if you're feeling any discomfort, okay? Just say ouch. All right. So, folks, this is a Duke laser disc repair like we've always done. The difference is, you feel something? All right, let me have some more numbing medicine. The difference here is really no difference, to be honest with you. We're going to get started by, apologize, I know that's uncomfortable. We're going to get started by numbing up the skin a little bit. Let me know if it's still bothering you, okay? So we do these surgeries live so you can ask questions and I can answer them for you. So you're welcome to ask questions. We won't tell you who our patient is or identify them, but we are going to let you kind of stand in and watch the surgery be done. What's that? Everything okay? Alrighty. So let's get a fluoro shot. I'm going to be talking to my team as we do this. Yep. Let's go to a lateral. It looks, may need to start a little bit lower. I think we may be a little higher than I want to be. Get some numbing medicine ready. Skin numb. Good, 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 good. Shot. All right, yeah, we probably maybe need to go a little bit higher on the table, actually. Yep. Shot. All right, so let's see if you can come south a little bit with the fluoro. It looks like 5-1 is right there. And you may not be able to boost. I mean, you may not be able to do the interrupted stream. You were pretty close, by the way. It's a little too low. Come back up to a little bit closer to where you were. Yeah, the changes you have to make are just minimal. Really like an inch. Sometimes half inch, sometimes quarter inch. Shot. We need to, all right. Well, that's probably pretty close to as good as we're going to get it. Shot? Yeah. Shot? Where do you feel that? Shot? You feel it in your lower back? All right. Just try to relax. Shot? Yeah. It's no fun. Shot? Yeah, you can see 5-1, right? Shot? You're doing great, by the way. That's the facet. You're doing really, really good. Shot? Shot? This is the worst part of the surgery. I apologize. I wish it was a little easier for you. All right. Num num. Let me have the big num. I'm going to see if I can make it a little more comfortable for him. A little bit more medicine, numbing medicine. Yeah, I apologize. We're trying to numb things up a little more for you. Make it more comfortable. Huh? Yeah. No problem, and I just can't put you to sleep yet. That's the only issue, so we're all right. So I think we were pretty close. We just need probably to start a little bit more lateral to where we were. Shot. And I apologize, folks, for those of you watching. The image quality is not great, but believe it or not, it's the best we can do. I need to see a little bit more than that. Shot. Are you pulsing? I don't know what that means. I don't want it pulsing. I need a good quality picture. Shot. All right. Shot. So our trajectory looks good. We're close. Wonder if we could do a little bit better. We had it better a minute ago. What I would say is bring me a 1/4 inch north and zoom me in a little bit more. Quite a little bit more. Bring me towards the patient. Bring this towards the patient. And try to use your collimator to get me a better picture. Get rid of all that dead space in the back. Yeah, it's not working. You're way overexposed. If you need Monica, we need to get Monica in here. Let's call her in. Yeah, so what you want to do is see all that space back there? You want to collimate that out. That'll allow the beam to concentrate more. Yeah. Yeah, see if she can come in. That's good. Let's try that. That's better. All right, that's a little better. That's a little better. Let's get Monica, though. I think we're still overexposed. See if you can reduce the exposure a little bit. Try one more shot there. Yeah, that is. No, this is a. I mean, we're pretty close. Yeah, if she can come help us, that would be wonderful. Shot. I'm having to use a lot of imagination. Still up against the facet. Let's get an AP. Is that an AP there? Holy mackerel, I can't see anything. That's better. Alright, well, we're definitely up against a facet, which is what I expected. Question is, I see a spinous process below. Let's go back to a lateral view. Shot. 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 Where do you feel that? In your back? Alright, everything's okay, Shot. Shot. You're so close. Let me know when Monica gets here. You're doing really good. We're very close to where we need to be. I just need a little bit more. Shot. 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 Yeah, we're there. I could almost make out that vertebrae. I'm thinking, there we go. Shot. Are you feeling any discomfort? Huh? Where? So you're back, but not down your leg. Monica, I need a better picture. This is 5-1 we're trying to get to. We're close, but I need to see 5-1 a little better. All right. Huh? That's almost good enough. Where do you feel it? All right. Starry, starry night. Huh? All right. It's a little better. Maybe you can move it south or north or whatever we need to do. Let's get an AP though while we're waiting. Are you boosting? We need to be maxing out what we're able to do. shot. Yowza, yowza. Okay, we gotta be able to do better than that. Come on, Monica. That's like a white Christmas here. That's a little bit too dark. All right. Well, that's pretty good on the AP. Let's get back to a lateral. I think we're very close. It's all Hazel's fault. Hazel's standing at the back of the room going, what did I do? All right. Nothing down your leg? Huh? You said no? Anything else you can do for me, Monica? All right. Where do you feel it? Huh? Low back. Low back still? Shot. Nothing down your leg? I need to see that L5-S1 a little better. So you're really overexposed. Maybe bring your emitter right up against the body. Try to get a better penetration and less background. We're close. We're very close. I apologize. It's so uncomfortable. We just need to confirm our location. If I use really a lot of my imagination, we're so close there, Monica. How could it be so over white? It looks overexposed. Can you darken it a little bit? Maybe post image processing? Bring up the contrast. That's a little better. A little better. A little bit. Holy mackerel. I have to use just a little too much imagination. Are you still uncomfortable? Where does it hurt you? But not shooting down your leg. That felt like a disc. Shot? That's in the disc. AP? This just might be your luckiest day. I've had to use a lot of spiritual and draw on my experience and my great imagination. Yeah, that looks good. All right, just stay there. Are you okay? They say it's better to be lucky than good. Let's hope that I was lucky. You comfortable? Did you get much back pain with this problem? 80%? How bad? That's it? All right. Shot, guys. What are you waiting for? An invitation? All right. 10 out of 10. Typical concordant pain. Let's do a lateral. We found it. We got lucky. Someone up there likes you. You get to go to sleep. When you wake up, we'll be done. All right. Let's get a lateral. Yeah, there it is. There's the herniation. So for those of you who watched me do this many times before, you can see how, stay here just for a few more minutes. You can see how we can't even see the spine. Now the reason for that is there's just a lot of soft tissue. And the x-rays don't penetrate soft tissue very well. So we're going to put our patient to sleep. Shot. We're not through, we're not out of the woods yet by any means, but we're close. I've got to be able to, yeah, I'm just manipulating your back a little bit. So we've gone right through the tear at L5. By the way, L5-S1 is the hardest to do. We just did L5-S1, and our patient is a very large man. He and I talked about this before, and he knows that there was a chance I wouldn't be able to do the surgery because he's a big guy. Do you remember what I had to do to get these out? You remember? How do you remember what I have to do to get this out? Jesus, Luis, you must be a genius. There's no doubt about it. That's exactly what I need, and the other thing. Good job. Are you serious? Have you been watching old videos? Luis, admit it to me. How would you know this is my trick? You know how many times I've had to do this? Very few. Very, very few. So how could you possibly know that? You're starting to freak me out. Have you been getting into my dreams? All right. So why is this significant? Because this patient has a lot of soft tissues, and what that means is it's really hard to do the surgery because the instruments aren't long enough. But we got lucky, and let me show you something, folks. This is just good for knowledge base and reference point. Here's the needle we had to use because of the excess of soft tissue. Here's the needle we normally use. Look at the difference. We would never make it to the spine with a normal needle. So we have a very special needle that I've had hiding in the back. Luis had to get the dust off of it and bring it out. But anyway, no, it's sterile. But that's what we had to use. And the problem is when you use a needle that big, you can't pull it out and keep the guide wire in. It kind of pulls the guide wire out with it. So it's bad. So I had to use a little trick, which Luis somehow knew. And he's freaking me out. All right, we're making an incision. We're on the left side. Everybody agree? Thank you. Luis, you don't need to say anything more today. You've just elevated yourself in my book. Now, the question is will this fit? And more importantly, will the tubular dilator fit? Because this is only so long. I have a feeling we're going to be taking this to the max. We're going to be maximizing our system. It's not designed to, be used on such big people. That's really not a nice way of saying it, but that's the best I can do. It's just the truth. Because big people are deep. They have deep backs, so we have to go much further than normal. And I'm just hoping that we don't have any problems getting down there. Okay? So, shot. So far, things are working out in this patient's favor. I hope it stays that way. So we're right there at the back of the foramen, and thank God he's not moving around. Shot. I'm almost on the herniation. And I apologize on the x-ray. It's really hard to see, but it's hard for me too, just so you're aware. This is not something we're doing on purpose. Shot. This is truly one of the most challenging cases I've had to do in a long time because of how deep this patient's back is. So the dilator is sliding along the guide wire. I can see the guide wire. It's kind of near the front of the disc. And I'm just going to keep advancing this dilator. And it's now going to go through, shot? It's going to go through the tear where the herniation is. And that's what I want. I want to bring this tool through the annular tear. That's right where the herniation is. So basically I'm entering the disc where the tear is, that caused the herniation. And by doing that, we put ourselves right into the spot that needs to be fixed. Okay, shot, so that's good. So basically we're going through the herniation to take out the herniation. I mean, right? You can't do any better than that. All the other surgeons that do back surgery, they take out the normal spine, the bones, and the joints just to get to the herniation. We're actually passing through the herniation. So we're letting the herniation know we're coming. Luis, we should see if they have a longer tube. You know, just contact Germany and see if they've got a long one. Anyway, this is what we're going to do the entire surgery through, is this little milkshake straw. Today it's a strawberry milkshake. All right. So, Cam, you think it's going to reach?
I think we'll be okay.
Cam says we'll be okay. Anybody disagree with Cam? Yep. What? Who disagrees?
I said I can't see.
You can't see? Oh. Well, I can't see either. Use your imagination. So Cam says that not because he's done this before, but because he knows me. He knows that I wouldn't even try unless I knew I could do it. Cam's smart. So he's saying, okay, well, I know Dr. Duke, and Dr. Duke wouldn't be sticking that tube down there if he didn't think he could do it. Right?
Correct.
So hopefully you and I are both right, because it sucks to be wrong. Shot. All right, well, I can see the dilator is in the L5-S1 disc space, and it looks good. But the question is, can I get the tube down? And so far, I have to say, things are going, honestly, better than I thought. Huh?
You might hold it.
No. I've done this myself a few times. What I don't want to do is advance the dilator. I just want to advance the tube over the dilator. Perfect. You can see that's what we're doing. Now I can promise you this will go all the way down to the hilt. Shot. Good, good, beautiful. So you can see the dilator tip is a little bit past the halfway point of the disc, probably around 2/3. And the tube is now almost in position. Shot. Almost there. I told you it'd go right to the hilt, didn't I? So I don't want to lose it. So what I'm going to have to do is put my fluid adapter over the top. Sucky, sucky. I love it. Shot. All right, that's it right there. Okay, so we're going to pull this dilator back a little bit. Shot, and see where we are. Yeah, looks good. Actually, we're plenty in. And we just can't lose this thing. Otherwise, we'd be opening the patient up to find it. Beautiful. You guys can get the fluoro out. So far, things are going well. Better than I expected. Get that fluoro all the way out. And actually, I knew a little secret. I knew I could push the soft tissues forward a little bit, kind of to expose the tube, because I've done it before. I've done over 1,200 of these procedures now. Pretty close to 1,200. And I've encountered a lot of different variations in anatomy. So each time that we get a variation of anatomy, we get a challenge. But look at that, right to the hilt. You all see that? There's absolutely no room. It's perfect. So the Germans, when they designed the system over at Wolf, they anticipated that Dr. Dugmazian would have some patients that would maximize the capability of the system. All right, so there's the herniation right there. It's stained blue because we put a blue dye in there. Now I'm going to go take some pieces of this thing out. Okay? You're doing great. We're almost done. 10 minutes and we'll be done. Let's just try to save a few of those. Everything okay? So, as always, the herniation never wants to come out as one big piece. Laser. So we're going to have to get the laser. Hey, lay still. Lay still. Help. Just lay still. Give me the laser now. Just lay still. Come on, man. Help him. There's no time. Watch it. Don't let it hit your face. You guys keep an eye on the patient. I don't want him off this table. Okay, we can't have him getting off this table. Cam, you be ready. All right, so as we've talked about many times before, patients that have the surgery are, they're sedated. You need help? We need somebody here helping. Get over there and help him, please. We need more help. All right, so while our anesthesiologist is working on getting control of the patient's arm so he can't lift himself off the bed. People do things reflexively when they're asleep and they're experiencing some discomfort. And we can't have our patients coming off the bed. So meanwhile, I'm going to try to get this done quickly so we can recover the patient quickly. The less time under anesthesia, the better for the patient. Let's get Ann in here, whoever else is available. I want to make sure we have control of the patient. The problem is that when you do anesthesia, the patients are a bit groggy. They don't really follow instructions. And he just kind of tried to get his arms under himself. So if you can help out, we need to... By the way, this is the herniation right here. It's like undulating. How are you doing with the IV? You have control of the IV? I don't want to lose the IV. All right, we're going to bring this back a little bit so you can see some of the tear and herniation. Sean, any questions from our audience? It's a low priority. Thanks. Is Gary in here? All right, good. All right, this will be our last surgery for today, so if you have any questions, feel free to ask. This is a one-level Duke laser disc repair. L5-S1, left approach because the patient has left leg weakness. He had it before surgery. I didn't get to talk much about that. But when I saw the patient in clinic, he had a little bit of weakness, but it's gotten worse. He's now starting to almost drag his foot. When I re-examined him in pre-op, he had a 4-/5 strength with the extensor hallucis longus, or EHL. That's the muscle that cocks your toe backward. And then the tibialis anterior was also a 4-5. That's the muscle that cocks your foot up. So definitely the weakness is getting worse, and he needs the surgery. There's the tear. There's part of the herniation right there. Oh, look at that thing. It's billowing. All right, let me have the grabber. I may be able to grab some of it out. It looks standby laser. If I can pull a big piece out, it would certainly. Why do I have water everywhere, guys? No, it's not wanting to come out. Thank you. Let's get that laser back on. Unfortunately, this herniation is stuck down. It's not coming out with the grabber. Why do I feel water on my feet? What the hell? How is that possible? Oh, it's definitely dripping down from the bag, but it may have stopped now that Luis adjusted it. No, that's something cold on my foot right there. What was that? You just dump another cup of water on it? All right, there's definitely herniation right there. Stand by. What is it? Where's it coming from, Luis? Do we have an idea? Look at that. Just do your best for now, but the corner of the bag is leaking? So the hose is leaking. It's not shoved into the nipple hard enough, is what you're saying. All right, just we're okay for now. I don't mind wet shoes. No, we're all right. I can just live with it for now. Let's just try to fix it for next time. All right. Nope. Leave it alone. I don't want to mess with anything. Flex seal, right. Sterile flex seal. All right. So for those of you who have never seen this, the blue fiber is the laser fiber, and it's emitting a burst of energy right at the tip. There's actually a little bit of glass, it's not an electrode, but a little bit of a glass cable. You see that right there? That's where the laser energy comes out. And what it does is it vaporizes the tissue because there's so much energy being delivered to such a small area of tissue. It literally vaporizes the tissue and disrupts the tissue into little bits, and then they float out. Okay? The energy can also stop bleeding. So there really is no bleeding inside a disc because the disc is avascular. I'm going to pull back a little bit more. Sounds like we might have a question. There's the tear where the herniation came out right there. See it all? Everybody get to see that? So there's a little bit of herniation still in there. That pink thing at 9 o'clock is the end plate. That's the L5 end plate. You can see how close the tear is to the end plate of L5. Yeah? Sean, have a question? Sure. I hear you. So, one of our viewers said, I had a microdiscectomy surgery at L4-5, and I got a lot better afterwards, but I'm still getting pain in my feet with walking. Feet plural, with walking. Do you think I'll need to do another surgery? Well, the answer is we need to know first what's causing the pain in your feet, and I'm not certain that it's a disc problem or stenosis. It could be a problem with your feet. If you're just having pain in your feet, you could have plantar fasciitis, Very, very possible. If the pain goes from your back down to your feet, then it's probably a nerve issue in your back, and that could require surgery. So really, I need to know more information about the foot pain. Is it isolated just to your feet, or does it radiate from your back down to your feet? That would be the first thing I want to know. And obviously, you said feet, so I assume you mean both sides. There's other things that cause foot pain besides plantar fasciitis. You could also have a peripheral neuropathy. Neuropathy is nerve damage to the little nerves in your feet. I need 5 minutes, guys, 5 more minutes, and I'll be done. So to answer your question about whether you need additional surgery, we first need to know why you're having your symptoms. And I can help you with that if you set up a Skype call with me. We do that for free. You just have to submit your MRI and talk to Sean. Sean will give you more information, but I'm happy to do an interview with you and find out a little bit more about your symptoms. We offer this at Duke Spine Institute free of charge, and we do it for people around the world, not just Americans, but anybody that wants a free consultation about their problem. Okay? Usually we give you about 10 to 15 minutes. We like to have your MRI first so we can look at it. So think about whether the pain is just in your feet or does it come down from your back. If it comes down from your back, you'll need a new MRI. So I can either order it for you or you can have your doctor order it and then submit it so we can look at it. All right, that's the herniation. I've been using the laser to slowly remove pieces of it. We're getting close to being done. There's the end of the disc right there. And I'm just going to finish this up here. So at 12 o'clock, you see a little wisp of blood up there. This stuff here is the back of the annulus or posterior ligament. So it's a transition zone between the annulus fibrosis and a little bit of posterior longitudinal ligament. Remember, the posterior ligament is not very strong laterally where we are. It's pretty weak. It's pretty undeveloped in human beings. That's why disc herniations most commonly occur right where the nerves are. Because the posterior longitudinal ligament is not very strong there. Posterior longitudinal ligament actually fuses. You got to help me here. You got to pay attention, okay? You see this kink right here? You should be keeping it from blocking me. You got to think of me as the sniper, okay? Your job is my support. You got to take care of everything I need you to take care of because I'm looking down the scope and I'm focused on the target and shooting it. You got to take care of everything else. All right, so anyway, you can see the posterior longitudinal ligament fibers fusing with the annulus right around here. And things start to get less dense. There's a piece of herniation there. I just blasted. There's a little bit left in here. I want to make sure I get it all. I don't want this patient having to come back. No, you're not stopping it. Look at it right there. Pull it. So did I answer the question, Sean, all the way? Sorry, I got a little bit distracted. But long story short, if you've had a microdiscectomy in the past and if your symptoms are coming back and you're getting pain going down your legs to your feet, then that's easy. It's a pinched nerve, okay? But if you just have pain in your feet, it doesn't mean you have a problem with your back. It could be a problem with your feet. So we have to sort, yeah. Oh, okay, sure. Go ahead, Sean. Oh, radiating down from the back. Got it. So our viewer has clarified their question, and the pain indeed radiates down from the back. Then yes, you have a pinched nerve again, and you will probably need another surgery. And by the way, that's why I don't do microdiscectomies, because when the surgeon does it, they take your bone out of your spine. It weakens the spine. It makes it more likely for you to have more problems down the road. For many years, like 100 years, that was the best surgery we had. But then in the 80s, 90s, this endoscopic surgery was developed, and it's much better because you don't take any bone out of the spine. Plus, it's a Band-Aid incision. This patient literally will go home 30 minutes after his surgery. Go home. Never be in the hospital. No stay overnight. Literally gets to go home. And can go back to work the next day. But this patient in particular has to bend over at work, so I'm not letting him go back and bend over. He has to go into jet planes and airplanes and make repairs. So if he does that, if he bends over and climbs through these little crawl spaces, he's going to hurt his back. He's got to let this heal. That's one of the problems with surgery is if you don't follow the instructions by the surgeon afterwards and let things heal properly, you're going to be back in the operating room for a second surgery because you didn't follow those instructions. So with this type of surgery, you're going to need to lay off of lifting, keep your lifting at 25 pounds or less for 6 weeks, and bending at the waist needs to be reduced. That yellow stuff you're seeing there is fat. Each little circle you're seeing is a fat cell. It's called adipose tissue. We're just about done. I need probably 2 more minutes. I'm going to show you the nerves in a minute, by the way. You guys will be able to see, most likely be able to see the L5 nerve root. This is the last of the herniation right in here. I want to make sure we get all this. I'm really expecting that his pain will be gone, and more importantly, his nerve will start to heal. Because remember, I told you I checked him before surgery and he was getting weaker and weaker with his foot. He was dragging his left foot. So he was at what we call 4 minus. Yeah, just 1 minute, 30 seconds to a minute left. Almost done. I don't want to rush it, but we're almost done. Damn pedal. So he definitely needed something done. Alternative surgery would be a microdiscectomy. We would have to make a much bigger scar and incision. We'd have to drill away bone like everybody else does. And now what we're doing is we're not taking any bone out. There's no scar. It's just a little cut on the skin. And everything is done arthroscopically. 20 seconds. Like a little vein or something. Let me see here. just trying to get a little bit more of this stuff here. It's all scarred in. You see all that yellowish stuff, grungy stuff? That's from the herniation. That's inflammatory tissue, all scar tissue from the inflammation. It's been going on since he injured his disc. And I'm cleaning all this up. This is called an annular debridement. Yeah, just about done. I'm almost done, I promise. I keep thinking I'm done, and then I see a little more that I can get. But this is the annular debridement right here, what you're witnessing this exact moment. I'm taking the herniation out that's stuck between the tear in his disc, between the torn annular edges. And that will allow the annulus to heal properly. You got to be careful when you go medial like this, because what I'm doing is I'm actually pushing on the tube, not the scope. All right, I'm thinking that's good. Let me get this out for a second. Let's take a look at the nerve. See how it's doing. It's right over here. There it is, right there. See that white thing? Okay, right there. Now it's at like, I don't know, 12 o'clock. That's the nerve. That was the nerve that was getting pinched. And the S1 nerve, which we're not going to see. Maybe I can get just a little more of that. Let me just get a little bit more. Laser on. Just about done. Hang in there. This is a good size herniation. We have a call coming in. All right, we're done. Yep, I'll take it. Yeah. So what's the chance of re-herniating the disc once it's fully healed? I would say it goes back to a normal disc. It's almost zero. The time that people re-herniate is usually within the first 3 months to 6 months. Let's get the scope off. And the re-herniation rate for this surgery is about a little bit over 1%. It's probably around 1.2% right about now, based on all of the patients. So your chance of re-herniating, let's just call it between 1 to 2%, or you can call it 1.5%. So 1.5 to 2 people out of 100 are going to re-herniate. And that's almost always because they do something they're not supposed to do. They're lifting something too heavy, or they're bending over at the waist. Pressure. So if you give it a full year and you've made it past a year, the chance of re-herniating is zero. And I say that because the people who have made it past a year, they don't come back. Maybe I've had one of them come back out of 1,000 patients. So you may say 1 in 1,000 will re-herniate after a year. Okay, so it's a very durable, great surgery. It lasts as long as you let the disc heal and get to a year. Let me show you the incision. All right, we did the whole surgery. You guys see this, Sean? Can you see that incision? Right there? Basically, it's half the width of a dime. All right, let's put pressure and let's cover it up. Great job, everyone. I'm going to come answer questions. Type your questions up. You've watched a left-sided L5-S1 Duke laser disc repair. And by the way, the first surgery, the posterior cervical laminectomy and fusion is ready to go, right? She was looking fantastic before I started this one. So we'll check on her as well. I'm going to call our EBL 2 mil.
The pain level got to about an 8, a 9.
The right side of my body from the waist down was pretty much useless and in pain constantly.
The pain was chronic.
It was an aching, stabbing.
It became unbearable. It became where I didn't want to get out of bed. I didn't want to talk to anybody. I didn't want to do anything.
I had the pain every single day in my low back.
It's torturous. I can't go to sleep at night. I can't lay down. I can't sit for too long. Can't stand for too long.
I couldn't sit. I couldn't stand. I couldn't walk more than 50 feet.
It's excruciating.
sends excruciating pain across my back, gets down to my hands where my hands are numb.
I had no life.
If you are suffering from neck or back pain, the Duke Spine Institute can give you the relief you need to live your life without pain.
Now I have absolutely no pain.
Not even 24 hours after the surgery was complete, I was able to be how I felt is normal. And it was good.
No scars, didn't hurt at all. As you know, when I woke up, it was totally painless.
The next morning, I was up and about and out, dressed on the job.
I have no pain. I'm living my life and doing great things, and I'm just very happy.
It's a great feeling not to be in pain.
Duke Spine Institute has changed thousands of lives. Isn't it time you live your life pain-free? Log in to dukespine.com or call 1-800-FIX-MY-BACK for a free MRI review and consultation.
I feel like a new man again.
And it's thanks to Dr. Duke. He gave me my life back.
Dr. Duke did an amazing job fixing my back. I recommend him highly to anybody who has any kind of back issues, any kind of back pain. Don't wait. Go see him. The relief is amazing.
The pain level got to about an 8, a 9.
The right side of my body from the waist down was pretty much useless and in pain constantly.
The pain was chronic.
It was an aching, stabbing.
It became unbearable. It became where I didn't want to get out of bed. I didn't want to talk to anybody. I didn't want to do anything.
I had the pain every